work with the Center for Deployment Psychology. I am a military internship behavioral health psychologist who is currently housed in a large medical treatment facility in Portsmouth, Virginia. As a part of their faculty, I participate in training and in also some research for the APA accredited internship programs and the doctoral program and fellowship. I'm also a practicum supervisor, and I really enjoy implementing DBT and other evidence-based treatments for PTSD. And so it's really my privilege to be able to meet with Dr. Harned today and get more information about this treatment, which I myself have never had the opportunity to implement, but look forward to using in the future. We just wanted to go ahead and talk a little bit about that and give an overall primer as to what Dbt-Pe is and how it works. So welcome, Dr. Harned.
Thank you for having me.
Yes, she is the developer of Dbt-Pe, and she developed this protocol in 2005 after receiving a large NIMH grant to formally develop and test the pilot of this particular treatment. In 2015, she was awarded a second NIMH grant to evaluate the effectiveness of the treatment. And Dr. Harned has received numerous awards for this advancement in treatment. Dr. Harned, I've just got a few questions, but I just want to thank you, first of all, for joining us today.
Yeah, I'm thrilled to be doing this.
Yes, it's wonderful. So I'm wondering, what inspired you to create the Dbt-Pe protocol for the treatment of PTSD?
Well, it kind of boils down to the simple fact that the patients I was treating really needed it. And I was working originally, just delivering DBT as it's typically delivered. I was working in Dr. Marcia Linehan's clinic as a postdoctoral fellow originally at the University of Washington, and really kind of in the thick of DBT and all that was happening in the DBT world and treating lots of clients, and just really aware that the people I was treating, many of them had PTSD, many of them had really severe and complex histories of trauma that were contributing to all the problems that brought them to DBT, like being suicidal, being self-harming, having really dysregulated emotions, all sorts of risky behaviors. A lot of it really seemed to be driven by their traumas and the PTSD symptoms they had. And DBT, as you mentioned, is an incredibly effective treatment. It has the treatment with the most empirical support for reducing suicidal behavior and really helping people with borderline personality disorder in particular. And one of the things from both the research side of my life and the clinical side of my life kind of converged to suggest that, well, it's incredibly effective at treating many things. It was having a limited impact on treating PTSD. And the people I was working with in therapy really needed it. And so I was sort of set out on this path to figure out how to make PTSD treatment accessible and effective for them, also because they're generally not considered good candidates for other PTSD treatments that existed. So we needed some new way to make this possible for that population of clients.
Yes.
Yeah.
So tell us about the structure and the course of treatment for those who might benefit from Dbt-Pe.
As you said in the beginning, standard DBT includes a variety of different modes of treatment. And so one thing just to make very clear is that this treatment, the foundation of this entire approach is standard DBT. So, we have not changed anything about how standard DBT is delivered. It's more that we've added to it. And so people are delivering standard DBT, which, in general occurs in a variety of different levels of care, which will influence how long the treatment usually is, of course. But sort of the most typical model and way that DBT is used is in outpatient treatment settings, where usually with adults, the treatment length is a year long. But that can vary. It's often shorter with adolescents. It's also shorter in intensive outpatient or inpatient or residential settings. So there's a lot of variation. It can be used in a variety of ways. But I'll talk about the standard approach, which is to typically do 1 year of treatment. And so we're specifically, because we're trying to do PTSD treatment with people who otherwise usually are not considered good candidates for other PTSD treatments, we're specifically bringing people in who have various characteristics that suggest they're not yet ready to do a trauma-focused treatment like PE. In DBT, we call that that they have a stage 1 level of disorder. So they're coming in with a variety of life-threatening behaviors, typically a lot of just general behavioral discontrol, very, limited coping skills, things like that. And so we start with standard DBT. Stage 1 of treatment is all about helping them to gain control over these different risky and life-threatening behaviors that they're engaging in. And that's done by increasing their ability to use effective coping skills to manage urges and emotions and all that kind of stuff. So we have that sort of first phase of treatment, which is just regular DBT. And once they do reach a level of sort of having sufficient behavioral control, where we feel confident that, or mostly confident at least, that they will be able to get through trauma-focused treatment, that's when we add in this additional, what we call the DBT prolonged exposure protocol, Dbt-Pe, where they then get this somewhat adapted version of PE, and it's kind of layered on top of DBT. So they're still getting all the modes of DBT at the same time. So they still have their individual DBT therapy, they still have DBT skills training groups, they still have their between session phone coaching that's part of DBT. And then as therapists, we continue to go to our consultation team every week. So they're getting all of DBT, and now they're also getting this extra DBT-PE as a concurrent treatment that's built into their individual therapy sessions. And then, we do that until hopefully they've gotten enough benefits and more is not needed. And then there's the option, what we ideally will have if the timing all works out, if you're doing a year of treatment, is that we still have some time after that. So we finish the DBT-PE and we go on to the sort of final phase of the treatment, which is back to just standard DBT by itself, where we're at that point targeting whatever's left, essentially. It's really up to the client to determine their remaining treatment goals, and we use DBT to help them reach them. And very often those are more related to things like psychosocial functioning goals. Once PTSD is really improved, it sort of opens up lots of new opportunities for people related to things like jobs or going to college, or often we are working a lot on how to improve the relationships they're in and build new relationships, and that sort of functioning kinds of goals, and sort of generally finding a new sense of meaning and purpose in life at that point is often what happens in that last stage of treatment, again, which is standard DBT.
Are there any exclusion criteria for participation in treatment? Who might be an ideal candidate for DBT-PE treatment?
Yeah. The most recent treatment trial that I conducted, which was the one in public mental health that I mentioned, we actually didn't use any exclusion criteria. So we took every patient who was in one of the DBT programs in those agencies who had PTSD and wanted to participate, and we didn't exclude anybody. So that meant in that most recent study, we had a really wide range of different types of clients in the study with different diagnoses, including some of the more typical ones like borderline personality disorder, but also including psychotic disorders and bipolar disorder, substance use disorders. Many of them had suicidal self-harming behaviors, intellectual disability, adolescence, so we sort of all comers. So that sort of approach is really what I would like, is anybody who is in DBT and who needs PTSD treatment, those are the people we're looking for. So generally speaking, then, in terms of like an ideal candidate, I think I would say we're looking for people who are appropriate for DBT. Like there's something going on that makes them quite severe and complex, and usually it's because they have suicidal and self-harming behaviors or at high risk for those things, that they need DBT, and then which makes them at the same time sort of not likely to be appropriate for PE on its own or another treatment like CPT on its own, where they really do need this concurrent approach and ability to have a sort of stabilization phase first. And so really, I think the only exclusion criteria I would say is that if you don't need DBT, like you don't need that stabilization and you are ready to launch immediately into a trauma-focused treatment, then those people should not get this treatment. Those people should go directly to PE.
Being proven to be effective. I'm wondering, what were some of the lessons learned in the creation of Dbt-Pe?
You know, probably the most profound lesson we learned very early on that really kind of blew us all away and still does when I think about it, is how much our clients want to do this treatment, and how hard they're willing to work in order to get it. And so, you know, myself and I assume probably lots of other people would maybe have the expectation in general with trauma-focused treatments that people are not going to be very interested in them. They're not going to want to take them on. They sound really hard and scary because they are, you know, like, and that if you talk to a highly suicidal, self-harming person with, you know, 17 other serious problems about like, so, hey, we've got this treatment and here's what you'll have to do is you're gonna have to talk about your trauma in, you know, really detailed fashion, and you do that over and over, and you know all of what that's going to bring up, and you know, that we would get people who'd mostly be like, no thank you, right?
No way.
And it's a balance. It's not like people are very thrilled at the idea and super excited to do it, nor at the beginning of treatment are they thinking that's a good idea for them in that moment. But like almost everybody, and I've done studies of treatment preferences of this population, it's somewhere between 75 and 90% of people who we've had participate in different preference related studies actually say that they would rather have a combined DBT and PE treatment over DBT alone or PE alone. And so there's such a strong preference for it that's there. And what that communicates to me is not that they're very excited about doing exposure. Absolutely not. That is not what they're communicating. But they're communicating how much PTSD is causing them to suffer, and how long for a lot of our adult clients they have been suffering with PTSD their entire life. And so the very idea that you have a treatment that might help them not have to suffer in that way anymore, and that you're willing to consider doing it with them, when often many of our clients have had the experience of being told that you know, people were not willing to do PTSD treatments with them. All of that is often novel and provides them with some sense of hope that actually this could be different for them. So what their preference is to not have PTSD. And they are willing to do a treatment that we tell them we think will work for them in order to get there. And once we learned that, it just sort of made us a lot more confident in starting to orient people very early in treatment, but also in sort of setting effective contingencies very straight out of the gate of DBT with these high risk people, of starting to talk to them about doing this treatment and using the fact that they want it when it's true. Of course, it's not true for everybody, but most people using that as a motivator to work hard and fast at getting these high-risk behaviors under control. So we usually tell people in the first couple of sessions of DBT, like, you know, hey, look, we've got this thing, we'd love to do it. We think it would really change your life, and we're totally unwilling to do it. As long as you're still trying to kill yourself, and as long as you're still self-harming and all those things. So you've got to stop those, and we're going to help you. But you know, we're going to need to see that you stop those. And we tell them, for example, you know, we need 2 months free from those behaviors before we'll even consider doing this with you. And it turns out that's incredibly motivating. And you know, much to our surprise, the idea of doing trauma-focused exposure is actually a reinforcer for most people. So we can sort of hold that out essentially as a carrot in some ways to help them get that behavioral control more quickly in that initial stage of treatment. And I never would have expected that going in. So that was sort of a really important thing that we learned. And I guess just broadly, sort of most interested in getting this treatment available to more people who need it, and sort of figuring out how to effectively disseminate and train people as we also continue to gather data about its effectiveness in a variety of different settings, and just sort of continuing to see whether its effects sort of remain robust as we sort of disseminate it out, which is ultimately the end goal is to hopefully get it to the places where people most need it and where this treatment, DBT, is most often delivered, and hopefully have it still be as effective as we've found it to be in other places. So that's where I'm sort of headed, is more sort of implementation research on this and getting it out into the world. So.
That sounds wonderful. I think that a lot more people could benefit from DBT-PE. So the more widely available that it's made and the more trained clinicians that we have who are able to treat all the clients that might need it, sounds like it would definitely be a dream. So good luck to you, Dr. Harned. Thank you so much for your time today. Looking forward to hearing more about your research and just DBT-PE going forward. Thank you.
Thank you so much for having me.